Okay, thank you very much. So we are talking about avoiding dissection and recoil, and Bruno, you will talk us later through dissection management, diagnostic and avoiding, and I would like to concentrate on the Spur Stent device, which is one of the new BTK devices trying to avoid dissection and recoil in patients with BTK disease. So what are our challenges in BTK disease? We discussed this during the 2 days already quite a lot. It's calcification, lesion length, and elastic recoil. Unfortunately, we have to admit that especially recall and dissection is present in our mind for many, many years already, but I think we never did an adequate treatment or avoiding of these issues. So what we are still doing is, and we discussed this already, we are talking about POVA BTK, and I think the POVA time is over because of the existing and well-known knowing issues with POVA in special balloon unfolding injury, barotrauma, and of course the inappropriate balloon expansion times, which definitely do not lead to a very long-term patency rates in our patients. So with these unique new devices, specialty devices, balloons and scoring devices, I think we have now the opportunity to overcome these issues with dissection and recoil. And this is the Spur device. This is a self-expanding nitinol temporary stent, which you can deploy in the BTK vessel between 2.5 and 4 millimeter diameter. This is the requirement. And you see this Spur stent has tiny spikes on that surface, and these spikes poke into the intima media and calcification. With this, it disrupts calcification and improves the compliance of the vessel. So you see with this device and the theory behind, you can modify the lesion morphology, decrease vessel recoil, change the vessel compliance as mentioned, and of course increase the acute luminal diameter, which is of course one of the most important aspects. Here you see a much closer view on this device. Two lengths and diameters are available, 3065 millimeter and 4060 millimeter, which again you can deploy in every vessel which has the diameter which you need to use this device. An extensive study analysis was done already for this device. The first man trial was conducted with 23 patients, but we have now two very interesting data sets available from the deeper outer US trial and the deeper Limes trial, as well as the deeper reveal trial, which is the approval trial for FDA in the United States. So I got you through a little bit to these trials. This is the summary of the existing publication of these trials. So far, over 250 subjects were treated across 4 clinical trials, as mentioned. And because of the location for this device and the indication, of course, patients with BTK disease and advanced Rutherford scale, typically 4 and 5. To make it a little bit time effective, I put the deeper our auto US and deeper Limes study together. So the device was used in conjunction with either paclitaxel device in the OUS trial or the Limes trial as the Rollimus balloon was used to determine the efficacy and safety of this device for patients with BTK disease and advanced Rutherford scale situation. Here you see the demographics of the patient in terms of diabetes, hypertension, hyperlipidemia. You can see on the right side that also very calcified lesions were included in this trial. You see the primary endpoints, especially in terms of primary patency rates between in these two trials. The deeper US trial had a primary patency at 6 months at 85.7%. Deeper Limes trial had a little bit set up in terms of the primary endpoints. You see freedom from major adverse limbs event and POD at 30 days, 96.2%, and then 6 month composite of all-cause mortality, major amputation, and revascularization of 11.5%. I think these primary endpoint both in these both trials clearly show the efficacy of this device in conjunction with an drug-eluting technology, either paclitaxel or sirolimus. Beside of the paclitaxel analysis with this device in conjunction, there was subgroup analysis performed in the DPOS trial, the vessel recoil sub-study, which was recently published by Professor Seller. They aim to analyze if after 50 minutes a reduced situation of the recoil answer could be seen after use of the Spur device. And this was clearly proven in 38 patients. As you can see here, you see that the elastic recoil in direct comparison to the already published Baumann paper from 2014 was significantly lower. And I think this is what we really want to see. We want to have a prolonged good efficacy in terms of patency, less recoil, less dissection. And this subgroup analysis clearly stated that this could be achieved with the Spur device. You can see that this also worked in calcification situations. So the calcification had not so much impact on this recall answer and had there was no relationship seen between the calcification and patency rates at 12 months. So this means that this device, if very efficacious from an efficacy standpoint, disrupts the intima media calcification very well. And I think this is definitely what we would like to achieve and to see that, especially in moderate and severe calcification, we have a good outcome and not severe dissection and recall answer. Aside of that, the deeper reveal trial, this is the FDA approval trial. Interim data are so far available. You can see on the right side that also very challenging situations were treated in this reveal analysis in the United States in terms of calcification. These data are not fully published yet. There's some interim data available in terms of the performance goal. You can see here the primary efficacy goal and the primary safety goal, which were highly met in comparison to already published data. So they are also on a very positive track in the United States with this device. Importantly to say, this is a non-DCB trial. So here the pure Spur stent was used for BTK intervention. So in conclusion, I think it's important to talk about specialty balloons in these times. We have not very acceptable procedure data and long-term data with standard balloon angioplasty. I think this is clear. We know that POVA causes a lot of intimal tears and dissections directly by unfolding. These dissection can directly lead to a restenosis cascade and, of course, to a significant recall answer. With specialty devices, we now have the opportunity to overcome these issues with dissections and recoil. Definitely, we need more prospective data. The question, of course, is do we really need DCBs or can we just use the specialty balloons alone? So a lot of questions are definitely still there. I think it's time to set up head-to-head trials also in terms of calcification. Is this device better than the other one? So I think a lot of exciting questions ahead of us and new studies are conducted to answer these questions. Thank you very much.
Thank you, Michael. Next speaker is going to be Bruno Migliara. He's going to talk about BTK dissections, either to